Hi guys, welcome back. We shall now be talking about nipah virus, where the initial cases were reported from a village in Malaysia. As you can see, a lot of pigs being culled together or killed together because of the outbreak, and then it obviously has spread to other parts of the world, including India. Then cases have been reported from Bangladesh. So let us just study about this virus and what's so particular about it, and what makes it so virulent primarily. When it comes to nipah virus, I would suggest you to watch a Hollywood movie by the name of Contagion, Contagion. And in fact, the description in Contagion movie in Hollywood is exactly same as that of nipah virus. So I don't know whether it was a stroke of luck that the Hollywood people came up with that idea, or actually they studied about nipah virus maybe better than what we did, and they came up with a movie. But it's a Matt Damon movie. Have a look at it on Netflix or wherever you can, and that would get you a better insight into how dangerous this virus can be. And nipah virus, well, it's a paramyxovirus which is related to the Hendra virus. Hendra virus is written as capital H small EV, not to confuse with the hepatitis E virus, just for the sake of mentioning it. So what I was saying was that initially the first cases were reported in Malaysia, and it was mainly the people who were working in the pig farms. They are the ones who were actually infected, and then ultimately obviously the disease spread to the local community, so they had to kill all the pigs per se to control the spread of the disease. And then they investigated where did the pigs get the disease from. So what they found was that in these pig farms they had planted a lot of trees on which the fruit bats were there, and well, the fruit bat obviously ate some part of the fruit, and the remaining part of the fruit, when it fell down, the pig ate it. So the fruits that were contaminated with the saliva of the bat or contaminated with the fecal droppings of the bat were the ones which were responsible for the pigs getting the disease, and then the abattoir workers or the people who handled the pigs getting it and then spreading it to the community per se. The name of the fruit bat is Pteropus. That is also called as flying fox by internet, but we as doctors tend to call it the fruit bat, that is the flying fox. Then you see bats which are in North America or Canada, they're mostly insectivorous, but the bats which are found in Asia, basically they are rather living on fruits. So initial cases were like the saliva of the bat or the droppings of the bat contaminating the fruit, and the fruit being consumed by the pig. And that was also the thought process for the outbreak in Kerala also initially. But I'll explain to you how the manifestations are different with respect to Bangladesh and Kerala. Though case first reported for nipah virus in India was in Siliguri in 2001, for Bangladesh and Kerala, guys, I would like to say that they have a predominant Muslim population, and eating of pigs is obviously, I mean, pork is considered to be a sin in, let me say, Muslims. So why is it that people who are not consuming pig meat are the ones who are the areas where the outbreak of nipah virus occurred? Because obviously these people are not gonna take pig meat. So what happened was, and they found this out, was that the culprit behind Bangladesh and Kerala outbreak was rather the date palm. You can see the top of the coconut tree here, the date palm sap is what they are harvesting here, and they put a pad, they put a container below this for harvesting of the date palm sap, and then the date palm sap is used to manufacture products like toddy, which is a local wine basically. So the date palm sap was contaminated with the saliva of the fruit bat, or it was contaminated with the droppings of the fruit bat, and that resulted in manifestations in mainly Bangladesh and Kerala. So they had to basically do a lot of, I would say, intensive study to find out how the bats are ultimately transmitting the disease to the human beings. So finally they have found out the methods of transmission, which I have said before you, and this disease also has a person to person transmission. Well, when I say person to person transmission, it is not aerosol of blood. It is again contamination with the saliva of the infected person. Like if this person is having seizures, the nurse who cleaned the secretions on the mouth of the patient after the seizure episode, she got it on her hand, and then she herself got infected. And unfortunately, the nurse in Kerala who got the index case in 2018, she unfortunately expired. So contact with the saliva of the patient is the one that is responsible. And most of the time, because neurological illness is something which will require a special admission into hospital. Now imagine Bangladesh as a country, one of the most populated countries in the world, and so is the case with even southern part of our country. I mean, medical facilities are not so vast. In one bed there might be two patients, so attendants are sharing the same premises as the patients, and obviously they are the ones who are taking care of the patient, because you see, nurses spend about total less than 10% of the total time touching the patient. It's mostly to adjust the IV fluid, give antibiotics, etc. But wiping the secretions of the patient, or talking to the patient, or coming within, I would say, less than 3 feet of the patient is something that a nurse is not doing. But still, nurses got this infection, mainly because of contact with the infected secretions of the patient. And people who have handled the dead bodies of these patients, because in cultural practices they wipe the body orifices after the person has died. So when you touch the body orifices of this dead person with bare hands, and there are no hand washing facilities subsequently, then again these persons who came in contact died within 4 days. I mean, that's how fast this disease can cause manifestations. So let's just quickly look at how the disease can be transmitted. One is via the sap of the date palm, which is contaminated by the fruit bat. Second is obviously the fruits, which are contaminated by the saliva. And the third one is a person to person transmission, that is close personal contact. Is the three methods of transmission of this particular virus. Nipah virus occurs naturally in certain species. It occurs naturally in bats. It can occur naturally in horses, pigs, even dogs. They are the natural reservoirs of this particular disease, but human beings are particularly vulnerable to this. So let's now look at what are the clinical manifestations that a person would suffer from. That would be features of encephalitis, and initially this disease was thought to be Japanese encephalitis, but then they realized that the manifestations were slightly different, in a sense that the patient was having even respiratory symptoms. So fever, headache, dizziness, altered sensorium are the usual presentations that would occur on day 1 of illness. Most patients would die by 4th day, and that would be secondary to either encephalitis related complications or ARDS. The medical reports also state that majority of cases also had myoclonic jerks or development of seizures. In some studies, they have also mentioned regarding development of hallucinations. In a nutshell, there are no meningeal signs in these patients. You can definitely observe in these patients abnormal doll eye reflexes. Babinski sign will be positive in this patient. Reflexes will definitely be fast. And then the patients were also having respiratory symptoms, which initially we thought that it is due to the requirement of the ventilator, because anybody who's on a ventilator, why we are putting on ventilator, the patient went into coma. So we thought that it is ventilator associated pneumonia, but later on we realized that this virus is not only capable of causing a neurological illness, but it can cause ARDS manifestations also. And I don't think so there's any virus as potent, as dangerous as Nipah virus at the moment, because one, it can cause death within 4 days. Second, it causes two things together, encephalitis and ARDS, and especially the ARDS component of this is fairly lethal, because you very well know the prognosis in ARDS is really bad. So let us now look at what is the workup which is to be done for identification of this disease. You can see in this image the fruits which are gonna be consumed by these bats. They fall on the ground. The pigs are gonna eat this. The pigs are gonna get the disease. Then there are some reports where even the horses have got this disease from bats, though it's from unidentified spillover, which is obviously not very clear from the CDC perspective. But people people who then are responsible for breeding of horses, maintenance of horses, and then maybe producing horse meat are the ones which are gonna be infected. And in India, it has been mainly date palm which has been incriminated, along with obviously fruits, for development of outbreak of nipah virus in our country. The government did very well to contain this epidemic. I mean, imagine a virus which can cause ARDS manifestation, encephalitis spreading in our country. There is absolutely no hope, and Indian population would just die like flies. For workup of this particular condition, the test to be done would be serum test, that is IgM class of antibody. We would do a IgM capture enzyme immunoassay, EIA, for nipah virus. That would obviously demonstrate the exposure to the virus, because if you're having antibodies against it, that means you are exposed to the virus. Then we will also do a immunoglobulin G antibody assay by doing an indirect EIA, that is enzyme immunoassay, for nipah virus, Hendra virus. CSF of these patients has also been shown to be positive for nipah virus by doing a reverse transcriptase PCR. And if you do a MRI head in this patient, the MRI head will show presence of punctuate hyperdensities. The reason for these punctuate hyperdensities in a MRI head of this patient has been ascribed to the vasculitis component that this disease causes. They have demonstrated the fact that this virus causes vasculitis, it causes microinfarctions in the brain, and the combination of the two results in development of acute encephalitis developing in a patient for which there is definitely no cure. Virus is something, this virus is something that Hollywood movies are made up of, as I've said, and there is no vaccine for this condition that we are obviously waiting for. And if we can develop that, that definitely means that our medical science has evolved over a period of time, that we can definitely control what is a potential category 3 bioterrorism agent, because category 3 means emerging disease. And if you read about agents for bioterrorism, you would have done MCQs like anthrax can be used for bioterrorism. That's obviously anthrax spores are easily available, but then category 3 is the emerging diseases which could be used as bioterrorism agent for future. So these are the details for the nipah virus that I want you to be familiar with. And we will next talk about Zika virus, which has again caused mayhem and can cause mayhem in future times to come, especially from neurological point of view. Let's now talk about Zika virus in comparison with nipah virus. Coming to the next topic, guys, Zika virus. This happens to be a single-stranded RNA virus belonging to the genus Flaviviruses. What I want you to remember for this particular infection is that most cases came to attention in 2016 with respect to the Olympics that were conducted in Rio, that is in Brazil, and that is when they reported a large number of children being born with microcephaly, which is a neurological sequelae. If a pregnant lady gets this infection, then the baby would be ending up with this neurological manifestation. The incubation period of the disease hovers between approximately 3 to 12 days, and then the patient would be having a fever that would last something between 2 to 7 days, something identical to that what happens in dengue fever. The transmission of this infection will occur via Aedes aegypti, the same one which is responsible for transmission of dengue fever, and man-to-man transmission and sexual route of transmission has been demonstrated. So that I definitely want you to remember that the man-to-man sexual route of transmission is demonstrated for Zika virus, and there are two main concerns about it. One, this can contribute to Guillain-Barré syndrome. The incidence of GBS has increased in those communities where this virus has been reported. And secondly, the pregnant women, if they have got infected with this virus during pregnancy, then they have gone on to deliver a baby with microcephaly. The clinical manifestations of the disease would be standard like dengue fever. They would be fever and a very characteristic retroorbital pain. You will notice this retroorbital pain even in patients who are having chikungunya, who are having dengue fever, and today with Zika virus. This would be associated with arthralgia, and then there would be a rash also. The arthralgia will mainly involve the small joints in the hand. It's small joints of the hand that would hurt mostly. So lots of time this disease will be initially misdiagnosed as chikungunya, and lots of time might be reported as chikungunya only, because not in all cases do we do serological testing. Rash will be noticed in patients who are having Zika virus infection, mainly around the palms. This would be on the chest, mainly also on the anterior abdominal wall. So most of the body would be having this characteristic rash all through the duration of fever, and this would be associated with the development of conjunctivitis. Thankfully, this is a self-limiting illness like any other viral illness. It is only the neurological sequelae that I've written on the top which are of concern. Therefore, MCQ wise, one, I want you to remember microcephaly can not only be seen with fetal alcohol syndrome or with Torch group of infections, but can be seen with Zika virus infection also. Definition of microcephaly is head circumference which is less than -3 standard deviation of the normal age appropriate ratio. Along with this, these children will also be having problems with their fundus examination. There might be an abnormal foveal reflex, or rather absent foveal reflex. Chorioretinal degeneration can be noticed. Macular atrophy can be noticed. Hypoplasia of the optic nerve head can be noted. So three features I said: foveal reflex is affected, macular atrophy, hypoplasia of the optic nerve head. And incidence of Guillain-Barré syndrome is increased in this patient. The Guillain-Barré syndrome is diagnosed by what is called as Brighton criteria. Let us quickly revise the Brighton criteria also, which are useful for diagnosis of Guillain-Barré syndrome. The first and the foremost prerequisite would obviously be a development of flaccid paralysis, which would be starting from the limbs and going in an upward direction. So first and the foremost feature of this would be a lower motor neuron type of a paralysis, which would start with a bilaterally symmetrical flaccid paraplegia. Both the ankle jerks in the patient would be lost, then both knee jerks would be lost. So it goes up from bottom to upward, so it is a ascending paralysis. The manifestations of the patient should be that of distal areflexia. What I mean by distal areflexia is that first ankle jerk and then the knee jerks in the patient would be lost. The duration of illness should be over less than 28 days. What I mean by less than 28 days is like in the first week legs got paralyzed, second week the trunk got paralyzed, third week the arm got paralyzed. So manifestations of progression of the disease should be over a duration of less than 28 days. Then the hallmark feature of this condition is albuminocytological dissociation, which means the fact that in this condition, the CSF cell count can be normal to slightly elevated, but the proteins are always elevated. You can see that albuminocytological dissociation will always point towards a diagnosis of Guillain-Barré syndrome in a patient. You should also be able to do nerve conduction velocity study that should demonstrate presentation of demyelination, and there should not be any other alternative diagnosis possible in the patient. So I'll just repeat the feature. You need to demonstrate lower motor neuron paralysis. It should be having distal areflexia. Progression of illness should be over under 4 weeks. If the progression is over 9 weeks, then we call it CIDP, that is chronic inflammatory demyelinating neuropathy, and I've discussed that in the neurology section also, but I thought I'll just use this opportunity to talk about features of GBS, which has lower motor neuron lesion manifestations, demyelination, and the incidence of Guillain-Barré syndrome has been found to be increased, especially in populations where Zika virus outbreaks have occurred. This disease is more prevalent in those communities or those areas which are below the height of 2000 meters. So you can see that parts of Southeast Asia, some parts of India, especially coastal India, starting from Gujarat, then going on to some parts of Tamil Nadu, and going on to West Bengal, they are the ones which are vulnerable, and outbreaks of Zika virus have been reported from even the central part of Americas. Then obviously Brazil is a hotspot for it, central part of Africa is a hotspot of it. So this disease has a predisposition for only those areas at a height where the Aedes mosquito can survive, and neurological illness is the main concern with respect to the spread of this virus. Let us now quickly study what is the way forward for diagnosis of Zika virus infection. In the workup for this condition, according to the CDC, if they ask in the exam what is the investigation of choice, your answer is a urine assay. Why urine assay? Because the virus is shed in the urine for longer duration as compared to blood. The test you will do in the patient would be answered as urinary trioplex PCR. Now, what do you mean by trioplex PCR is written as RRT PCR. What does it stand for? Well, it stands for the word real-time reverse transcriptase PCR. I repeat the data. This is a combination of real-time reverse transcriptase PCR. Like normally we only do a RT-PCR, but here we are doing what is called as a real-time reverse transcriptase PCR, a trioplex urine, which is useful for identification of Zika virus. On the blood sample of the patient, however, we will do a standard reverse transcriptase PCR only. To demonstrate that somebody has got this infection, ELISA for IgM class of antibody for Zika virus will also be done. The problem is that this antibody occurs after 7 days. So if you get a MCQ saying what is the best way for diagnosis of Zika virus, the answer is point number 1. As I said, the antibody appearance takes some time to appear. In case these tests are positive in a pregnant lady, then serial ultrasound should be done to demonstrate whether the baby is having a development of microcephaly and a brain calcification or not. Apart from serial ultrasound, with the permission of the mother, amniocentesis can be done, and on the amniotic fluid we can test for antibodies and we can do a PCR also. So these are the guidelines as of now. The vaccine has not been developed as of today while we are discussing this topic, but I definitely want you to remember these two infections in comparison, that is nipah and the Zika virus, which have been discussed here, and because both of them are relatively new infections which have been reported in the recent 1 to 2 years, the media highlight has been on them, so I have thought that I should discuss them before the exam before you. Thank you so much for listening.